where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning. Hey, good morning, everyone. If I turn off the logo. Welcome to UroNurse. I'm your host, Vic Senese. Glad to have everybody here. Hey, if you're joining us for the first time, don't forget to like and subscribe. We've got a great episode for you. We've got Susanne Quallich, who's going to be presenting for us, and my co-host, Lori Atkinson, who's going to be joining us. Let's bring them both on the screen right now. Welcome.
Good morning.
Morning.
All right. Give 1 second here. It's going to do a quick introduction on today's program. So today we're honored to welcome one of the most respected voices in urologic nursing, Dr. Susanne Quallich. Susanne is a nationally recognized leader, educator, author, and advanced practice provider who has dedicated her career to advancing excellence in urologic care and improving patient outcomes. Her contributions to urologic nursing education and clinical practice have helped shape the specialty for healthcare providers across the country. Today, Susanne joins us to discuss an important and timely topic. The latest updates from the American Urological Association. She's fresh back from it on vasectomy guidelines and what nurses absolutely need to know. So help in welcoming Susanne to the show. Welcome, Susanne.
Oh, it's always a pleasure to be here. And you'll have to forgive me if I'm kind of very nasally today. I have the pleasure of having a really significant head cold. So just bear with me, and I think we'll be okay.
And like a true nurse, you're here.
Right. I'm here. I showed up. Right.
Oh, I'm too sick to come, So, all right. Well, I'm going to turn it over to you, and then we'll come back for questions.
All right. Perfect. Okay. So we thought, actually, I was really pleased to be able to be invited to present this. And this is a great day for it because we're heading into June, which is Men's Health Month. So this is obviously a very male-oriented topic. And on top of that, the AUA actually updated their guidelines for this year. So it's very timely all around to give you a new kind of perspective on the AUA and their view of vasectomy. I'm going to venture to say that many of you who have who are involved in urology practices are familiar with vasectomy. Either if your surgeons are actually performing vasectomies, or if not, you certainly know peripherally what vasectomy entails. I want to give you a little bit of background on vasectomy because I think that sometimes we don't always know what's running in the background with some of these things. When the Affordable Care Act went into place, there was a lot of celebration about it. But there were some things about it that didn't benefit male patients as well as it benefited populations as a whole or women patients. And you can see what I have written for you here. The Affordable Care Act requires coverage for contraception, and most of the plans grandfathered that in, including sterilization procedures for women, with almost no or very low cost to patients. It doesn't require anything, however, the Affordable Care Act doesn't require anything in the same domain for reproductive capacity for males. And I think that's important. And in particular, if you go to healthcare.gov, it actually states this: plans are not required to cover services for male reproductive capacity issues like vasectomies. And so what this does is it can create, for some populations of our male patients, it can create access issues to this procedure. And I think you'll see how significant that is when we talk about what a very straightforward procedure vasectomy really is. Female sterilization under the Affordable Care Act is generally covered. Vasectomy coverage depends on the plan. So the Affordable Care Act left this up to the plan, the Medicaid program, employer, state law. Some states require coverage, some states don't. And as you can see there, 9 states required some state regulated, so like Medicaid plans, to cover vasectomies with no cost sharing. So again, I think, if this is one of your states, great. You can counsel your patients with confidence that they can access vasectomy, but you can see that that's not true across the whole country. Contraception issues in men, in general for men, are a problem. They're not covered by, excuse me, they're not covered by insurance companies. It's not mandated by Medicare, understandably so, because that tends to be for older patients. But we do know that women's reproductive care issues have been covered and studied for a very long time. And we just don't have that same information, the same quality of life information data that we have for women. And this is just to give you a little bit of perspective on that. Sometimes during a vasectomy consult, men are very much getting into all of these details. So the new guideline is there. You can see the link. You can go to the AUA website, search vasectomy. It'll pull the link right up for you. You can read all of the details if that is your inclination. But I'm just going to summarize them for you here. We want to start off with first off is that vasectomy is very safe. It's minimally invasive, and it is a very effective means of permanent contraception for men, as long as the individual patient does the post-vasectomy follow-up, and we'll talk about that. More than 500,000 vasectomies are performed annually in the United States. And you may be saying to yourself, wow, that seems like a lot of a single procedure. But again, there are issues with access to vasectomy. There's issues with knowledge about vasectomy. There are some ideas that either men or couples have about vasectomies. We'll talk about those a little bit, which really prevents men from accessing or pursuing a vasectomy. It is one of the most common outpatient procedures performed by urologists or urology providers. I should say that. Greater than 500,000. That's a big number. It's 500,000. Vasectomy consultation and procedural volumes have increased more than 150% following the Dobbs v. Jackson ruling in 2022. If you don't remember this is the ruling that overturned Roe v. Wade. And so it changed the reproductive landscape and access to reproductive services in the United States. We saw a lot of interest in vasectomies and a lot of interest in vasectomies from younger men. So I think that's an important thing to consider as well as we go through this. Consultations for vasectomy, according to the AUA guideline, can take place in person. That's never the wrong choice. We have shifted at Michigan to doing a lot of these virtually, which I think is really convenient for patients. They can do it on their own time. Basically, they can just take a short break from work in order to do this vasectomy consultation. So it goes into that idea of improving access to the service. It is intended to be permanent. Oftentimes I get questions right out of the gate. Can this be reversed? And we do tell them yes. We always tell them yes. We'll talk about that a little bit too. But I also kind of pause at that point, because if you're approaching this with the idea that you're going to do it and then just plan to reverse it at some point in the future, that this might not be the right time for a vasectomy for that individual patient. It's also not immediate. There is a waiting period before we declare you sterile or free to stop other methods of birth control. And vasectomy is not 100% reliable. It's very, very close to 100% reliable. The number in the guidelines is 1 in 2,000 for men who have had that post-vasectomy check that was negative. So it is still possible, but it's very uncommon. The consultation does require or suggest that we hit some of these points that you see here. A repeat vasectomy, very uncommon. And the thinking behind that is that sometimes that scar tissue that can form between the ends of the cut vas can have just enough little channels in it for a couple of sperm to get through, and then necessitating a redo vasectomy. There are options for fertility after vasectomy. So again, it is intended to be permanent, but that doesn't mean it takes away all the options for reproduction post-vasectomy. They do get increasingly more complicated, though. Vasectomy reversal is a much more complicated procedure than the vasectomy itself. And certainly sperm retrieval for in vitro is expensive on both sides of the equation, the male and female side. Surgical complications are there. Anytime you break the skin, there's going to be a risk of infection. We also see risks of hematoma, and infection to be 1 to 2%, as quoted by this guideline. Chronic scrotal pain is also at the rate of 1 to 2%. So that's a rate of 1 to 2% for the rest of your life after the vasectomy. And the way I tend to counsel patients about that is that it can happen at 2 years, 12 years, 22 years. But it's not this big thing anymore. We have an algorithm for how we can address that. And there are other permanent and non-permanent alternatives to vasectomy that are available. And primarily, these are things that would be offered on the female side. Oral contraceptives, and totally blanking, IUDs, things like that that can provide long-term coverage, but that are also reversible. As part of the consultation for patients who seem very focused on that idea of reversal, we do recommend, or that guidelines rather recommend, that you talk about cryopreservation as an option. So if they are really looking to hedge their bets, so to speak, they can be offered cryopreservation, but it isn't something that we necessarily offer to everybody. Consultation should also include that the vasectomy is not associated with the risk of sexual dysfunction or change in ejaculation. Those are probably the top 2 questions I get asked during the vasectomy consultation. And I'm always very clear that the anatomic area that we are in for the vasectomy is far away from the nerves, the blood vessels that have anything to do with erection or ejaculation. The AUA guidelines also specifically state that you can have the partner there, but that it is not a requirement. Now, individual practices may have their own special directives around this, but in general, the guidance from the AUA guidelines is basically that this is an individual choice, and the guidelines really support that as an individual choice. The last point here is sedation. Some practices do the vasectomy with a straight local. They perform it in the clinic with a straight local. There are practices that offer sedation. This can be something like pre-procedure Valium, in which case it's very, very important that the patient signs the consent form before taking the Valium. And some practices also are moving to using nitrous oxide in this context for sedation. So if sometimes, like if you've had, I know when my kids had their teeth pulled, they use nitrous. So there are some other options out there, but in general, the overwhelming number of vasectomies are performed with the straight local, the nerve block. There is, at some point, the patient does need an exam, and the way that this works in our system is that if you have a telehealth visit for the vasectomy consultation, the day of the vasectomy, the surgeon will examine the patient just to make sure that this outpatient clinic vasectomy is the best, safest choice for them. Sometimes it isn't. And sometimes for patients, particularly men who have a higher BMI, we do also offer them a second appointment in person specifically for a physical exam. We try to avoid people being canceled the same day for a vasectomy if possible, but we do understand that given the constraints of life and travel, that they may not want that kind of second appointment specifically for a physical exam. And we do honor that, and we'll do the physical exam in person. Varicocele is another thing that I get asked about a lot. Varicoceles do not impact whether or not we can successfully perform the vasectomy. And as I said, the body just BMI and body habitus can sometimes impact the ease or the safety of a clinic vasectomy. There are some patients who benefit from peri-procedural antibiotics. These would be the same folks that need antibiotics for dental procedures, but in general, we don't use antibiotics. And the guidelines don't specifically require require antibiotics. Rather, it is a person by person basis based on their history and current comorbidities. We do need to talk at this point about a female partner. I would ask for a show of hands, but we're on video. There's been a lot of times where I've had vasectomy consults for men who are 55 or 60, and we always take a minute to ask about the age of their partner. So if their partner is roughly the same age, there is really no need to do a vasectomy. If they are postmenopausal, there's no benefit to doing a vasectomy in that context. Some people do like that added layer of safety, and that's fine. We still honor that request. Sometimes what we do is we recommend that they return to either their primary care, the female partner rather, return to their primary care, or return to their OB-GYN if they're still following with gynecology to have an FSH. So if the FSH is elevated, it does indicate either, perimenopause, postmenopause, and meaning again that the vasectomy is not necessary. We approach this from the perspective that we don't like to do procedures that we don't need to do. If you can eliminate 1 to 2% chance risk of infection, we're going to eliminate that with a blood draw to check the partner's FSH. Likewise, if the partner is pregnant at the time of vasectomy, unless we do some counseling, I should say, and really offer them the opportunity to just wait or to have the consult, complete the consult, but not schedule the vasectomy until after birth, just to sort of make sure that everyone is happy and healthy at the end of that pregnancy. This is the no slide. These are the things that if patients or their partners have these questions, you can always tell them no. This is very explicitly spelled out in the guidelines. If you are interested in the studies that back up these statements, these evidence-based statements, I encourage you to go and pull the guidelines, take a look at them yourself. No link between vasectomy and prostate cancer. No link between vasectomy and the development of high-grade prostate cancer or increased prostate cancer mortality. No link between vasectomy and an increased risk of cardiovascular disease. And no link between vasectomy and kidney stones. There are some other things that have floated around out there in terms of urban myth type stuffs that go along with vasectomy. Another one that I hear about a lot is vasectomy and low testosterone. Absolutely not correct. There is no causal link between having a vasectomy and having low testosterone, causing low testosterone. For a while, there was a link that vasectomy is called Alzheimer's disease. Absolutely not true. And really, traditionally, and some of you may have heard this, excuse me, what this is that patients who have present for vasectomies, sorry about that. Okay, just breaking in here. I'm so sorry. Patients who present for vasectomies, what they will do is then stay engaged in the healthcare system a little bit more. And so we all know that if you show up, eventually we find things. And so some of these sort of urban mythy causal links, what people had thought were causal links, really are just that it was overall health issues because men were presenting to clinics for routine follow-up. Vasectomy is a safe and effective means of permanent contraception. I don't think we can underscore this enough. Tubal ligation has a higher failure rate. And tubal ligation, if you're not familiar with that, is the intra-abdominal parallel procedure for women. And what that is it's actually intra-abdominal. Sometimes it's done as part of a C-section, but sometimes it is just a scheduled procedure for women. So much higher morbidity because it is a full anesthesia intra-abdominal procedure. And so what this is it makes vasectomy a much lower risk procedure for our patients, and fewer risks, faster recovery, can be done in an outpatient clinic. So it's a whole different domain in terms of these options for men and women. This is a schema of a vasectomy, and what we do with the vasectomy is the way that is usually done is called a no scalpel vasectomy, which is our clever way of saying we don't use a scalpel to make an opening in the scrotum. We use a pair of scissors and kind of poke a hole, and we make that hole in the middle of the scrotum. And because the scrotal skin is loose enough, we can actually just take that opening and move it from side to side and do both parts of that vasectomy through that one opening, which is really nice for patients because then there's only one thing that has to heal. So we will take it to one side. We will identify the vas. We will pull a loop of it through that opening, kind of strip all of the tissue off of it, remove a section of that tube. And then there is, through some method, and there are a couple of different options that are detailed within the AUA guidelines, we burn it closed. Sometimes you put the bovie into the vas itself and kind of burn a little of the internal tissue. A lot of different ways to do this. This image tends to actually shows tying off the tubes. There's a lot of different versions of this. They all can provide azoospermia or no sperm after the procedure. When we're done, we also cauterize that opening that we made in the middle of the scrotum. And so patients leave our clinic with a scab on the scrotum, but no stitches or staples or anything that they have to come back to us for. Pain control, we recommend just non-opioid oral analgesics. Acetaminophen in the short term, a couple days later, they can start adding in anti-inflammatory medication. When I do the consults, what I always emphasize to people is you're getting a nerve block so that you don't feel the vasectomy. When you leave the clinic, you are going to feel great. You're going to feel no pain. Don't wait till it hurts to start taking Tylenol. Start taking Tylenol as soon as you can, either as soon as you get to your car, as soon as you get home. Don't wait for it to hurt, and then take it for the next 48 hours around the clock. Post-vasectomy instructions, depending on the facility's policy, they may require a companion to drive you home. This is going to be particularly true if they have any kind of sedation. But for someone who is undergoing the vasectomy with just a straight local, they don't need a driver. The analogy that I usually use is that we've all probably all had cavities filled, and we don't need a driver from the dentist. Avoid strenuous activity for 7 to 10 days. Again, this really depends on what their lifestyle is, what their job is. Those folks who do literal heavy lifting jobs, firemen, policemen, landscaping, things of that nature, we definitely want them off on that longer side. I like to see 2 weeks if it's possible. And certainly we're familiar with writing letters for that. Shower after 24 hours, no bath for 5 days. And you can use a cold pack, the bag of peas that we all talk about. I think that's good advice. And these are certainly all things from a nursing perspective that you can discuss with patients, or if they have questions afterward, this is something that you can provide this sort of information through their portal or over the phone call. A couple more instructions. Expect some mild pain and mild swelling. That's how the scrotum heals. It likes to swell. So some postoperative swelling, even if you are very, very careful in terms of your activity, you will have some swelling. They will also have some drainage. That is an important teaching point. Oftentimes we get phone calls that wound on the scrotum is still oozing a little bit, and that's okay. The analogy I always use is it's like picking a scab. Sometimes you get a little drainage with that. As I said earlier, extra strength acetaminophen or ibuprofen is perfect. I recommend avoiding ejaculation actually for at least 10 days after the procedure, largely because I'm the one that gets the phone calls when it hurts post-vasectomy. So I like to try and decrease the number of phone calls. But 7 days is okay. 10 days I think is a little bit better. Exercise recommendations is another big thing that we talk about. If they are folks who do a lot of running, who do a lot of cycling, they're going to notice discomfort during those activities. And so I really recommend that they're very, very low key with that again for 10 to 14 days after the procedure. They do need to use another method of birth control. This is part of the counseling. We talked about that a little bit earlier. We emphasize that throughout this vasectomy process. We need some time for that to heal up and for them to test post vasectomy. If they have any pain or unusual pain, unusual scrotal swelling, high temperature, their contact information. They will also be scheduled for a sample drop off at one of our clinics 3 months after their procedure. And the instruction that we have is that someone will read that within 3 weeks after drop off and post the results to the portal, unless they don't have an active portal. And then one of our nurses will give them a call. Vasectomy complications, these are out there. The AUA specifically calls out that basically anyone who's doing a vasectomy needs to be able to identify and manage any of these potential side effects that may happen, potential complications. There are no comparative studies about what approach is best in terms of suspected infection, things like that. And it's really left up to the judgment of the either the team or the surgeon or APP that did the procedure. If there is a post vasectomy, as I said earlier, a couple of years down the road, and it fits more into this paradigm of chronic scrotal pain, the AUA now has guidance for that. That was released last year. There's a whole section in that guideline that specifically addresses chronic testicular pain or post-vasectomy pain syndrome. Post-procedure follow-up. This is where we bring in the post-vasectomy semen analysis. The guidelines state that you can have it as soon as 8 weeks post-vasectomy. We at Michigan did kind of an internal consensus, and we decided that we go with 12 weeks. We felt that based on our history and looking at our samples previous to this change, folks who had dropped it off at 8 weeks sometimes weren't clear. But almost everyone at 12 weeks was clear. So we just pushed that out for our personal policy to be 12 weeks. It's considered successful as soon as we confirm azoospermia or no sperm in the ejaculate, and then we relate to the patient that they can stop the alternate method of birth control. We are permitted to examine post-vasectomy samples in clinic. In many places, that piece of evaluation is rolled into the package price of the vasectomy. And what we see now, though, is that there are mail order kits that are available, which really increases the convenience factor. And it is also potentially increasing the follow-up and the consistency, the adherence of follow-up to these post-vasectomy samples. When I started in this job many, many years ago, one of the many things that I discussed with the nurses in the first few months I was there, that if someone called and said, I had a vasectomy and now my wife is pregnant, the first question to ask them and document was, did they have their post-vasectomy sample? Did they do their post-vasectomy sample? Because these were not always patients where we had done the vasectomy. They had relocated. We're a big university area. And so that was always one of the most important things to document was, did they go back for their samples? So there's always some interesting conversations there. Again, in terms of this follow-up and this looking at samples afterward, there are a lot of variables. There is some limited literature on this, and there are a lot of variables that really impact whether or not men are going to have their post-vasectomy sample. Some of it is just as basic as the clinic didn't provide a cup, so they didn't feel they had a way to transport a sample. Did they have a scheduled visit? Like I told you, we schedule it. Was there a big distance? They felt that it was like not convenient to drop off a sample. Kind of bleeds into this idea of test location, home versus lab. What is the timing? How quickly do they need to drop it off? How does that clinic address touch points? Like, are they sent reminders? Are there automated reminders to do the sample drop off? And do they can they expect to be billed with that sample drop off? As I said, for our facility, it's rolled into the price of the vasectomy, so there's no additional billing for it. And this idea of touch points is some clinics will have nurses do quick either portal or phone call follow-ups to say, hey, we didn't get a sample from you, and to remind patients to drop that sample off. Historically, vasectomies had been one of the most litigated procedures for urologists. It's still in the top 10, but it's not as litigated as it used to be. I think that there's a lot of debate about it. You want to make sure that people do their follow-up, but also they've consented, and that's part of the consent process. So the approach to that is going to be based on a clinic by clinic basis. Many couples will, or men can be advised to discontinue when they have azoospermia, or that they have a certain number of rare non-motile sperm on a formal centrifuge sample. Frequency of ejaculation may also affect time to azoospermia, especially for men who are older. A lot of the times, men are looking for a number. There's no number of ejaculations. I really shy away from that because people have different patterns of sexual behavior, and if someone doesn't ejaculate more than once a week and is perfectly happy with their behavior, it's not appropriate for us to say, well, must ejaculate every single day post vasectomy. So just be mindful of that. And really, if they have to do a second sample, they have to do a second sample. A vasectomy, how do we get more men to engage with vasectomies? Some of you may be familiar with this idea of March Madness vasectomy clinics. There's been a lot of movement to try and tie vasectomies into sporting events. So you see that with the Masters tournament, or Focus on Fridays as vasectomy day. And this is just a way to kind of generate some camaraderie around the idea of a vasectomy, or just kind of make it easy for men to take a couple days off as they move for their vasectomy. There are options for fertility treatment after vasectomy. We talked about this a little bit earlier on. Repeat vasectomy is necessary in less than 1% of men. These would be that small percentage of guys who just have persistent sperm post vasectomy. For that reason, that maybe some tiny channels have been left in that scar that bridges those two ends of the cut vas. We can do vasectomy reversal. There are some factors that can impact how we counsel patients in terms of the likeliness of success of that vasectomy reversal. One of the big factors is just time since vasectomy. You know, if they're 18 months post vasectomy and presenting for a reversal, chances are good that's probably going to be successful. Also, female partner age and whether or not those partners have had children before. There are a lot of predictors that influence that, and we can also do sperm aspiration. And option for fertility will always be, there's always donor sperm as an option too. The hidden issue here is when we're talking about this, it goes back to some of those early slides, is that the Affordable Care Act doesn't mention fertility care for men. So when we start talking about things like vasectomy reversal or sperm aspiration, oftentimes it's not a covered benefit. So these are out-of-pocket things that men would have to pay for, couples would have to pay for. And so it goes back to the slide kind of in the middle there where I said, if we're talking to someone and their focus is vasectomy reversal, or how successful vasectomy reversal is, we really want to pause and say, maybe this isn't the right time for the vasectomy for them, because we know on the back end that there is no coverage and no payment for that vasectomy reversal. It tends to be out-of-pocket money for folks. So again, making it non-accessible to people. Future directions for the vasectomy. Requests for vasectomies are occurring at an earlier age. Men are opting for this as a way to manage their fertility at younger and younger ages. I think the most recent young consult I had was 22, was a graduate student. So you just want to take an extra minute to make sure that they're really confident in their choice. One of the things that has some data on it is this idea of regret after vasectomy. We know there's a little bit of data out there. These are some of the factors that tend to factor into that idea of vasectomy regret. They're younger? This reversibility issue may not have been well explained. They may be impulsive, and they may how many children they already have. So there's some factors that can impact that. Future directions in terms of non-surgical options. This is kind of exciting. We heard about some of these at the AUA. Some of them are hormonal. There's been a lot of interest over the last 15 years looking for a hormonal contraception for men, just like women have as an option, but it's not ready for prime time yet, as they say. And then non-hormonal contraceptive approaches are pretty interesting as well, just kind of targeting some of their actual sperm reaction for fertilization. And then interventional procedures actually injecting something into the lumen of the vas itself that might dissolve over time. So there's some interesting things coming up in the future on the landscape for male contraception. So we are wrapping this up here. 75% of vasectomies are done by trained urologists. This does now extend into APPs, urology APPs that have been trained. You will see nurse practitioners and PAs and midwives sometimes offering vasectomy services. Formal consultation is really a requirement. We have often discussed whether or not we want to do vasectomy consultation and procedure directly one after the other. Our perspective has always been we want to do the consultation, kind of let that sit for a minute, and then have the men schedule on another day. Other practices may have a different perspective on that. The sample can be submitted 8 to 12 weeks after the procedure, and men have more options for that now, not just dropping off at the lab, but also they can do mail order samples, which increases that convenience level and possibly adherence to that post-vasectomy sample need. Excuse me. I'm always available for questions. That is my email address there. And happy to take any questions that have come up during the course of this.
Yeah, that was a great review. I'm going to ask you right off the beat, what was kind of the difference with the new guidelines versus the old ones? Some of the things I picked up on was more consultation, it sounds like.
They clarified some of the consultation points. There's a big section that actually talked about these future directions. They hadn't really addressed that much in the previous ones. And there was also a big section about the mail order kits. Since the previous guidelines about like roughly 5 years ago, the mail order kits have really, there's been more and more companies, and I don't know how many, but more and more companies offering this at home mail order kit option. And so they needed, that was one of the big drivers of the revision, was just really talking about that this is an option. They don't fully endorse it. The language is very, very careful to say this is an option for patients. Again, all the data is in there for anyone who's interested in it. They don't fully endorse it as being equivalent, but it is an option that increases adherence. So that was one of the big things that got addressed.
Yeah. And then this is the other thing I kind of noticed was the update for the post-vasectomy analysis. So the recommendation now is as early as 8 weeks post-procedure, and long as the first one is clear, you only need one to get clearance, right?
Right. That's a big change. It used to require 2 samples. And we used to do ours at 8 weeks and 12 weeks. And I want to say that the European guidelines were always 12 weeks. But like I said, we looked at our own internal data. And that we saw that most people were clear at 12 weeks. And we have a lever door and he lets himself in. Honestly, it's insane. So we just decided to make one sample at 12 weeks. And what it did was it decreased provider workload of looking at the samples and nursing workload of relaying those samples to the patient. So it was a win for everybody. And then really it was just that commitment to one post-vasectomy sample for folks too.
Lori, what's your office do for post-vasectomy?
So we have them submit a sample 3 months after. And then if it does come back rare non-modal, then they're considered, or negative, then they're considered good to go. One of the things I think that in our office there's a little controversy on is we have them go to the lab, and the lab guidelines, the normal range, this is the part that gets a little hairy. The normal range for the amount of ejaculate is, I think it's between 2 and 4 or 2 and 5. And then you get those samples that are 1 milliliter and they're negative or rare non-modal, but can you still consider that a negative because it's out of the range?
Yeah, we do our samples in clinic. The providers look at them, but sometimes there's like you're struggling to find the sample, and I'll just basically veto it and be like, there's nothing here for me to look at. Excuse me. So I do think that that's a policy, to discuss with your facility. We send, it is only, excuse me again. It is only those guys who have persistent sperm in their sample that we send them formally to the lab, because they're going to get billed for that. So we try and keep that within the idea of this package pricing for the vasectomy for as much as possible. But it is a good point, and the guidelines are not super clear.
As far as follow-up, what we do, well, not everybody, we have a lot of providers, so they're all a little bit different, but some of them will actually have them make a follow-up appointment for 3 months after the vasectomy. That way, when their appointment comes up, if they have done their sample and everything's done, we can just cancel it. But that's kind of the way that we follow up with people, some of our providers. So
Yeah. It is an area that there's a great, we just have we just have MA appointments for the sample drop off. There's no provider, no intended provider contact. And it's tough because, these are adult people who have signed a consent form that includes that idea of follow up. And so what is the real responsibility if they no show or they don't drop off a sample?
right.
So our office actually had a policy before all these newer things came out of doing 3 samples every 6 weeks, one at 6, 12, one at 18 weeks. And as long as 3 came out negative, we were happy with it.
Yeah, well, I remember back in the day where, you'd get a rare non-modal and you're still following up and and then you're like, increase ejaculations, do another 12 to 15 ejaculations, do it again. And it can go on forever until we finally would send them for a formal semen analysis, at a
that's really the default. I think if there's any question about what's going on, whether it's been long enough to where you're not sure if it's motile or not, just because length of time till you look at it, is the lab. The default is always to have a formal study in the lab. That gives them peace of mind, and it also clears your practice legally about any gray area.
Just out of curiosity. Sorry.
Yeah, just Suzanne, you're getting an international audience here. We have somebody coming in from
Nice.
Barcelona, Spain.
Welcome, everyone. I think you're up. No, you're this is midday for some of you, I think. Early for me, maybe, but midday.
It's later. So it's like afternoon. So it's really interesting that such a variety. So go ahead, Lori.
It's such a good topic because the vasectomy is there's all these different perceptions of vasectomy, depending on definitions of masculinity, on the culture in individual areas, on what the education has been around vasectomy. It's really, 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 really interesting because I think as a whole, vasectomy is very straightforward. I talked about tubal ligation, and compared to that, vasectomy is very straightforward, but it's not often presented as a contraceptive option or as a way to prevent family building in some countries. And so I think there's a lot better education that we as the global urology community could do around vasectomy.
And Laura, you had something you were going to say?
Yeah.
I had a question because I'm not real familiar about these at-home kits. Mm-hmm. Are these kits that they mail back somewhere, and how do they keep the sample fresh?
That's a great question. So these kits, you can either order one directly, or there are some practices that will have them on site and either roll them into the cost of the vasectomy itself, or in order to get your results, you have to register the kit, which means you have to pay something for it. But the preservative, it comes with a cup. It comes with a preservative that's designed to make it stable for mailing. And so you mail it back to their lab. They look at it at their lab, and then they, through their portal, through email, they will send results. It's really great. One company in particular, I don't know if I'm allowed to call it out, but Fellow also offers the opportunity on the other side of that. So for actual fertility testing, not just for post-vasectomy testing, but for couples who maybe are curious why they haven't gotten pregnant, it offers a mail order fertility semen sample, if that makes sense. So the technology is just moving forward to where we're making this much more consumer friendly, and I think that's a great thing because it can only improve adherence.
So the other thing I saw out of it, I think that's a change, is the guidelines strongly now support minimally invasive vasectomy approaches, such as the non-scalpel vasectomy with combining mucosal cautery that you spoke about and the facial interposition. So I think that our standard for a long time at Michigan has been this minimally invasive approach, but it's not everybody has had embraced that up till now. They had done, and so the difference between what I described as a minimally invasive approach and what you may still see out there is you would actually have 2 incisions, one over either vas. So that would be considered not minimally invasive. As opposed, and it doesn't have so much to do with
how the vas are actually tied off or occluded. It's really that scrotal, how you address the scrotum piece that determines minimally invasive versus not minimally invasive.
Yeah.
It is pretty cool. Like I said, they leave our clinic with just a puncture wound basically. So it heals pretty quickly.
Now, as somebody who's been in the business for 40 years, I had one of the old-time urologists. He did the double incisions, and he would take out, no kidding,
Yeah,
that big, and he bragged, none of my ever fail. Well, yeah,
probably
you just
true.
dissected most of the vas.
Yeah, and certainly we see that, and it is effective, and I get it. He's trying to do right by his patients, but the disadvantage to that is then it limits the reproductive options down the road. Is there's no way to reconnect that, so you're really leaving that particular patient. If he has another partner or has life circumstance changes, the only way to get sperm from them then is going to be either testicular or epididymal aspiration, which increases cost, because then you have to use in vitro fertilization. So as effective as that is, it does limit options if life circumstances change.
Yeah.
I think one of the things way back in the day that they've changed too is I've been in urology quite some time, over 25 years. And one of the things that we used to do is always send the vasectomy tissue off for pathology. Yeah. And so we don't do it anymore unless there's question. We'll send it, but that went to the wayside as well.
Yeah, I didn't. And thank you for pointing that out, because I did not include that in the slides, because it's less of a nursing thing. But there's no need to send it for pathology anymore.
From a nursing standpoint, these minimally invasive procedures, that single small incision, makes your phone calls a lot less.
Mm-hmm.
Those guys with those big incisions, they would get big hematomas, sometimes massive scrotal swelling, all sorts of complications from that.
Yeah, as I always say, for any scrotal surgery, the scrotum likes to be left alone, and the way that it heals is it has an inflammatory response that's really can be quite profound, and then over time everything kind of goes back down to normal. So to your point, the less we can do to get that all mixed up, the happier our patients are going to be.
Yeah. Well, it's been a great explanation of kind of a review of what goes on with vasectomy and kind of getting us all caught up with what the new changes are. I think it really makes a lot of sense to kind of look at these things from a scientific, evidence-based, rather than just, what people have done for years and years and years. So it's great. It's new now that the APPs are doing vasectomies.
Yeah.
So that's
officially, yes. Unofficially, no. Unofficially, APPs have been doing it for a while. Yeah. You would always hear, kind of random family practice or internal medicine practices that would have APPs doing it. But with this recognized shortage of urologists, APPs are really being taught to do more and more of these office-based procedures.
Absolutely.
And the key really is just to know what's on the other side, how to deal with hematomas or abscesses or pain issues on the other side. That's the big key, to make sure that folks are trained on what to do in those cases.
All right. Well, great. Well, I'm going to put a little plug in for next week's episode. It's a big one.
We've reached a major milestone, the 200th episode of UroNurse. In this special anniversary episode, host Vic Senese, Lori Atkinson, and Dr. Jeff Albar take a look back at the journey of UroNurse and our other great podcast. We look at how the platform has grown and what's ahead for one of the most trusted voices in urologic education and nursing insight. From early beginnings to becoming a widely followed educational resource for clinicians, patients, and healthcare professionals, this episode reflects on the evolution of UroNurse, key educational topics in urology nursing and patient care, audience growth, feedback, and community impact, behind-the-scenes insights, and what's coming next for our podcasts and programming. Join us to celebrate on May 23rd at 9 a.m. Central Time to learn more.
Yeah, looking forward to stuff. I can't believe this is $199.
Yeah.
I'm so impressed. Like I think I said last time, I just think this is such tremendous service that you've grown, Vic, and it's great to be a part of it. So thank you.
Yeah, and that's what's been the fun part, is having people that are willing to come on from all over the world, even to, I kind of spread and share their knowledge, because it's huge. That's how we learn. It's how we do better in our job. And Lori's been with me from the start, which has been great. So it's been fun.
It's been fun. It's been fun.
Join me, because his show has been doing great too. So a lot of great things happening out there. And hey, sometimes you just want to celebrate. So everybody join us next week for this great episode, 200 episodes of UroNurse. Never missed a one.
That's crazy.
All right. Well, thanks again for coming, and we'll see everybody. Hopefully see a lot of you next week, especially all those ones coming from Spain and India. Join us. It's fun.
Absolutely.
All right, Laura, see you next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.